Okay, good evening. Welcome, everybody. It's great to have you with us. Put it in the chat. Tell us where you're from, and of course, which poster stories you saw and you liked. We are here to hear from our storytellers who have showcased some great innovation at the front line, and we are so excited to have you here. So let us know you're here by writing into the chat. Dr. Saad Khan from Jeddah, Mirjana from Croatia. Okay, thank you for coming. I'm waiting for some Africans. Do we have Africans in the house? Welcome as well. Dr. Namin from Egypt. Yes, Nigeria, Cape Town, Kenya. Well done. Yes. Do introduce yourselves. Botswana, Nigeria. It's really good to have you guys here. We are asking a question about which poster story inspired you. We've had all of the 34 stories up on the website, on the LinkedIn page of the Africa Community of Practice. And that means you probably got a chance to have a look at them. Was there a story that gave you an idea about something you can adapt in your own setting? That's what we want to hear about. That's what we want to hear about. Welcome, welcome. The Sinead is being kind enough to share the link in the chat so that you can have a look at it if you haven't. I see people from Egypt, from Cape Town, from Johannesburg. Thank you for joining us. So please now begin to answer the question. Have we had a look at the posters? And is there an idea that stood out for you? Um, as you introduce yourself in the chat, that's the question I have for you. We'll at around 5 minutes past the hour, we will officially start. But it was such a pleasure to look through the 34 story submissions. Nigeria led the way with 17 submissions. Kenya and Ghana had 5 each. Ethiopia had 3. And South Africa had 2, Uganda had 1, and Egypt has 1. And the Africa Community of Practice Steering Committee, we are clapping our hands to everybody who is innovating, measuring progress using patient safety and quality improvement principles in their work, and even better, telling the story to empower and inspire other hospitals, other frontline healthcare workers to do the same. So we are shouting out every one of these 34 who shared their stories. We are very super excited about you. One of the things we know we definitely want to do in the coming year is have more and more of us using this platform, this Africa Community of Practice platform in ISQua, to share the stories we've learned. As we gain improvements, as we gain knowledge about how to improve, why don't we share these stories with everyone else around us? So it's very exciting. So I see a lot of names from multiple places and telling us they're here, but nobody's answering the question I'm asking. Which poster story inspired you? What idea did you want to adapt in your setting? That's a question on the right side of your screen, I hope. You can tell us a little bit about that. So yes, Sinead reminds us that there is simultaneous translation available. If you click on the 3 dots at the bottom of your screen, usually you can toggle and find translation in your language. I think we have it in French and several other languages available on the continent, so feel free to use that. So it's 5 past the hour, so let us go ahead and begin to celebrate this World Patient Safety Month through storytelling. We are very glad that each and every one of us are participating. My name is Ruth Paunganga. I'm from Kenya. I'm a part of the Africa Community of Practice Steering Committee, but I'm also a part of the AfCOP Frontline Healthcare group that is supporting healthcare workers across the continent to get trained and do more experiential in practice patient safety and quality improvement work. And we are so glad to be a part of this month's webinar. This month's webinar exists to celebrate frontline innovation at the front line. We are going to hear from 5 storytellers from 5 different countries. But before then, let me just walk us through our schedule for today. So we selected 5 of the speakers that we thought would be of interest to you, and they are here already to share their reflections. Each speaker will share their story in 5 minutes. They will tell us what is it that stood out as they were seeking this improvement, as they were figuring out the problem, as they were putting together the team. These are all skills that will be useful to all of us. But before we hear from the speakers, I'm inviting 3 of my core members in the Africa Community of Practice, 3 lovely ladies, to have a reflection about why does the storytelling at the frontline matter? Why do we need to talk about quality improvement at the frontline? How do we build a culture, a sustainable culture of change, which supports healthcare teams at the frontline? That is the thing that we are going to spend a few minutes on next before we hear from the speakers. And then after we hear from all of the speakers, we have a good 30 minutes just for the audience, all of you, to speak and share your own stories. I hope some of the other 34 storytellers are here. I hope you who may not have shared your story also are ready to share what is it that has worked for you, when you're trying to get frontline improvement projects going. But let's go ahead and begin. I'm going to invite let's start with Chika from Nigeria. She's a chair lady of the AfCOP steering committee. Chika, come on, tell us. Why does storytelling matter in healthcare and quality and patient safety? What have you found about why does it matter?
Well, can you hear me? Can you hear me?
Loud and clear.
All right. Well, first I want to say congratulations to everyone, those who turned in a storytelling, and those who are sharing their stories with us today is really important. I think we started this really to ignite and illuminate the interest in the sector, the interest that we all see that quality is for everyone and we need to do something about it. Now, if we didn't have this opportunity to reach out, we wouldn't know all the great work you guys are doing. Some of these stories put me in tears. Now, let me go ahead and answer the question so we could get along. I have 3 major reasons why we should share stories. I think we do this because we turn the quiet know-how into safer care for today. And what does that mean? We all have strength, right? And this is why I love the strength of the frontliners, because you usually know how to fix the problem. But the microphone and the platform to actually elevate those voices are often lacking. So you walk around it, you know how, but storytelling gives everyone, illuminates the idea that the problems you're having, I have it too. And you figured out a way to do it. And maybe I have this one, we have this one, maybe we could share ideas together. So that's number one. The second one is it builds up this culture that protects patients and staff, right? It speaks to the culture of safety now that we know that these hospitals in these countries are into quality care and safety, and you guys know each other. And the likelihood that you want to collaborate because you have a shared aim, really for what? You center the patient and the staff. And the last one is that you spread, which is sort of ties back to the first one. It spreads to the work. You spread your ideas, right? It's about reliability, it's about scaling and spreading what you've learned so that other people can learn. So if you read through some people's stories, you may think, oh, I'm having that issue. Maybe I can actually reach out to them, and it promotes this culture of collaboration. There are 1,000 reasons why we should really share our stories. But these are the major ones. And more importantly, recognizing that the problems you're having are not unique to you, is so important. So I'll stop here. Thank you for the opportunity.
You've hit the nail on the head, Chika. I said nobody shows up to work wanting to do bad work. We all show up to work wanting to improve. And so what a gift it is to share with others we've made and inspire them to do the same. But let me invite Salome to also tell us what are some of the reasons why storytelling matters in our healthcare quality and patient safety space.
Right. Thank you very much, Rufpel. Hello, everyone. And thank you all for joining for us to celebrate Patient Safety Day. So as Chika said, we truly appreciate the diverse innovations in driving change by sharing your stories. We really enjoyed reviewing all the stories. I came across this Indian proverb which says that, tell me a fact and I will learn. Tell me a truth and I will believe. But tell me a story and it will live in my heart forever. Right. So telling stories is very, very important because one is an impactful way of learning and then connecting with patients and then their families. Another reason why we have to tell story is because it shows accountability and it also gives some agency to the improvement work that we are doing. So for instance, you are in a particular ward, let's say you have recorded falls for a period of time, and then you put this together and then you share with the management, and that alone is an evidence for management to come in and then intervene. Another reason why we have to share stories, most importantly, when we add data to it, is it makes the cases that we are sharing, the story we are sharing, more relatable. So Chika, Rupel, I think I will end here briefly so that I'll give the rest of the time to my other colleagues to also share. Thank you so much. Thank you.
Thank you, Salome. Thank you for helping us remember that the story is what lives in us. So I wonder whether we are all right now thinking about what is that thing that I did this month that I should have shared with everybody. Because God willing, next year we will have a chance to ask you to share your stories again. Will you all who are a part of this webinar ensure that you're also a part of the storytelling? Okay, so over to you, Rhoda. Why do you think storytelling matters?
Okay, thank you, Rupal, and thank you everybody who's joined today and everybody who participated in this context. Rupal, I love stories. I have learned and grown through stories from the time we were children, being told stories, up to now. And the way I consume stories in this current time in healthcare is through reading research articles. But once in a while, when I sit in a conference and somebody shares their story,
Keep going, Rhoda.
all right. So once in a while, when I sit in a conference and somebody shares their story about how they did something and they achieved something, they got this kind of results, I get so excited. And so I find storytelling to be a very effective way of communicating complex situations, health systems, complex ideas, and in a very simple manner. And I hope today we'll get that simple manner. All these complex ideas that were put in those 34 posters will be translated in a very simple manner, and we'll be able to understand. And through that sharing of these 5 stories, the 5 people be coming to share their stories, we'll be able to pick ideas that we can implement. So it is also an opportunity for us to listen wide and listen keenly and see, okay, this idea worked in South Africa, or this idea worked in Nigeria. How can I bring it to Kenya? Where can I start? How did they start? How did they build up? How did they scale? Is it something that I can do in my capacity, with the resources that I have, without having to really get strained and frustrated about it? And then if you don't tell your story, it remains an untold story. So nobody knows about it. Nobody can relate to you. And so you remain with this very good thing in you that nobody else knows. So I hope, as you say, next year when we do a call again, that we'll get to hear more and more stories. The untold stories in your small setup will become told stories in the world. Thank you.
Thank you as well. So I hope Chika, Salome, Rhoda have persuaded you that storytelling is something you should be doing. And I hope we are all reflecting and just saying, how am I telling the story of my work, the improvements that I'm making in my work? How am I bringing the lessons to bear so that others can learn from it, so that others can actually perhaps even reflect on it? And now we are going to move from theory, the idea of storytelling, to actually hearing real life stories. And I want to invite Meleku Gemechu from Ethiopia to go ahead and share his story with us. I'm going to skip over to his poster right here. How did this start, Meleku? How did we end up with a surgical safety checklist being utilized in this rural primary hospital that you're a part of in Ethiopia called Wondo Genet Primary Hospital? Please go ahead and tell us that wonderful story.
Thank you. Thank you, everyone. And thanks for having me. I'm excited to share with you our quality improvement project, which was intended to increase adherence to the surgical safety checklist, which has been shown to be effective in reducing surgical site infections, miscommunications in the surgical setup, and reduce risk of surgical site infection, mislabeled specimens. But adherence to this surgical checklist has been low in our hospital and in other similar resource-limited hospitals as well. So we tried to integrate in our workflows through indirect means like giving short trainings in the OR, training each individual in the OR, and even mandatory implementation has been tried, but all failed. And prior 6 months before our intervention, our average surgical site surgical safety checklist utilization rate has been 50%, which is way below the 100% national target. So we took the initiative to implement a quality improvement project to enhance adherence to the surgical safety checklist and decrease the rate of surgical site infection in our surgical setup and increase the communication in the OR. So when we start our intervention, we assembled a team that comprised of quality improvement director, general surgeon, and gynecologist. And after that, we went into collect the barriers which has hindered us from achieving our goal. So we conducted root cause analysis and gather change ideas from the staff, as we have to integrate the frontline staff into the projects that we are going to implement. So based on the change ideas gathered, we applied a single cycle PDSA method for improvement, and with selected interventions from the change ideas being giving a structured 2-day training in the OR, and translating the surgical safety checklist into the local language, as language barrier has been a challenge. And we went to integrate debriefing and briefing in the operative setup based on literature reviews and benchmarks. And we also integrated a mandatory pause after the skin has been closed, so that the timeout, the third part of the WHO surgical safety checklist, could be completed. So we integrated other changes as well, and the project took nearly 3 months, with additional 3 months to monitor our results. So within 3 months, we successfully achieved 100% surgical site safety checklist utilization rate, as well as completion rate. All the 3 parts of this checklist were completed by the end of the third month. And we went into an audit the next 3 months as well, and we were able to maintain the adherence rate at 100% for the next 3 months, in total being 6 months. So finally, our results showed that we have successfully achieved 100% utilization rates, and secondary indicators like surgical site infection has been 0 over the 6 months. This partly is due to the low surgical flow we have, and we operated nearly 86 patients within 3 months. And the other balancing measure was the time it took us to induce anesthesia in the OR. And we estimated a rough estimation of perceived time before anesthesia induction. And by the end of our improvement project, everybody in the OR claimed that their perceived prolonged time to fill this surgical checklist didn't prolong over our intervention period. And it was just a misunderstanding, a lack of understanding about the surgical checklist. So finally, what we have learned from this project is moving from evidence-based practice to evidence-based practice was key to achieve our success, and involving the frontline staff into leading the project, conducting on audits on a rotation basis. Everybody in the OR was involved in conducting the audits in rotation basis. That created a sense of ownership and accountability as well. And we learned that integrating this frontline staff into change ideas is essential. Plus, to change any new idea or to integrate any new idea into the healthcare system, we need to understand what the systemic barriers are and understand how the system in the healthcare is complex, and navigating every system as a team is mandatory. So we worked as a team, and we successfully achieved our result, and everybody contributed to the change ideas up to the level of publishing this report, selecting a journal. And one thing we had as a barrier was we didn't get any papers online that could guide us how we could integrate this surgical safety checklist into our practice. So to break that barrier, we went into publish this paper so that other resource limited setups can also learn from our practice. And here we are presenting it and sharing it to our colleagues in Africa. Thank you, everyone. If you have any questions or comments, you're welcome.
Thank you very, very much, Meleku. We are very grateful. I think we can react. So we have that reaction button. Let's give him some thumbs up, some claps, some I got you. And please feel free to use the chat to ask questions, to comment. Do you also have good surgical site infection utilization at your hospital? Is the checklist being utilized? We would love to hear about that. But because he's kept time, allow us to skip on to the next person. I'm going to invite Gerald from Kenya, followed by Aisha from Nigeria, and then Eunice from Ghana, and then Dikeleti from South Africa in that order. So Gerald from Kenya, I hope you are ready.
Yeah, thank you very much. And good afternoon and good morning. I'm Gerald from Kenya. So I'm going to take you through a project that we carried last year, actually this year. And it was on enhancement of communication between patients and the caregivers. So we, first of all, we began by forming a team of 10 people. So this is a team drawn from consultants, managers, nurses, communication officers, and quality improvement coordinators. Now, we then asked ourselves, what is the magnitude of the problem? So we wanted to find out the root cause. So the first thing we did, we utilized the tools that I'm sure most of us have interacted with, like the process map. We also had tools like Fishbone to help us get to the actual root cause. And at some point also, we used the Pareto, which I'm sure most of us are familiar with. Now, those assisted us in coming up the actual root causes, so that we now could decide what are these critical things that you're supposed to do to initiate or to enhance communication between the staff and the patients. Initially, the reason why we settled for that is because after a survey was done, we realized that the element of communication among staff and the staff was quite low, below 60%. And it was worrying because when a client is not happy, then you don't speak to them, then it means their satisfaction levels as well goes down. So after the root cause, we established that we need to settle for an intervention, and the most appropriate intervention that we picked, which could enhance that communication, was on sensitization of staff. We wanted staff to be giving client feedback, and also at the same time, we empowered our clients so that they can seek for information from the caregivers in the event that is not happening. So we did that for some time. So we developed some materials to sense the staff, majorly there's both virtual and physical. And for the patients, we developed very simplified materials to empower them, to help them get them more empowered. So that at the end of the day, when a staff comes to serve them, they are empowered to ask, what is happening to me? Which interventions have you taken place? What is the possible prognosis? So after a while, we reviewed if our interventions were working or influencing the communication. And we found that indeed, yes, there was a change because the elements of communication started moving from 70 and went to close to 90 after some period of time. So, and for this, we used run chart to measure the improvement with time. And when we realized that this is it, now, and it has worked, we kept telling the staff, the medical that we had picked were narrowed to a specific area as our scope was the ward. We call it medical ward. So that was our ground that we tested our intervention. So every time there was a change, we could invite or update the staff that the stakeholders, those are not the staff that work in that department. Oh, it didn't. Your work, your communication is making changes. Patients are getting more informed now. They are happier and they are better informed. So now the lessons learned from our interventions is that one of the basic things that you need to do to make sure that your QI project peaks and is sustained, choose a project that has impact. So if that will have impact at the end of the day in terms of financial impact and also customer satisfaction as well. Then we also learned that when we involve staff from inception, there will be better buy-in and they will own their project. And then use tools. There are tools that you use in QI, tools that can help you. Don't struggle because the tools are already there. They have been tried and tested. Use them too to analyze your data and to help you in having something that has quality. Then when you're collecting your data for your project, be more structured, involve the right people, and also at the same time, if you, for the purpose of buy-in and sustainability, involve your top management so that they can give you time to work on the project, and then they can also support you with other resources, including sometimes you need equipment, if you need to use the internet and so forth and so on. So top management buy-in is very critical. And for sustainability, every step, anything that you do, any forfeits, if you have challenges, keep documenting them because they'll be used by other people who want to have a project similar to yours. So they can use what your learning points to avoid pitfalls. Then finally, for the most sustainability element of fund, so working for us right now, we decided to integrate the element of improvement into our systems. So what we've done, we have what we call performance contracts. So we have integrated a QI and as an indicator of quality in all departments, so that people can use the same format that you succeeded with to initiate their own QI projects, and then guided by the teams that took part in this project, help them to sustain and grow. So we did a workshop for all departmental QI champions where they picked the project for the year. So at the end of the financial year, next year, they will have an opportunity to showcase what they have been doing to the rest of the departments in a symposium, which will be and then that symposium will have about 40 or 41 presenters, where each of them will learn from the other cohort work. And this is the best way to make sure that the QI projects are initiated, and then you build an army of improvers through subjecting them to such projects, which they can learn from and share with their colleagues, and even who knows, even the entire world. I'm sure because the projects are from diverse topics, then it will really showcase how people can improve the lessons that the departments have learned, and then the world will be informed as well. Thank you very much.
Thank you, Gerald. You know, one of the things you told me is that your institution has actually taken this as a KPI. Tell us a little bit about that as we transition to Aisha.
Yeah, so as I mentioned earlier, every department has a performance contract, which are the targets that they are given to run the whole year. So this time, through the support of the management, we introduced an element of QI, and specifically, whereas every department is supposed to come up with at least two quality improvement projects based on their scope. And then, we asked them to appoint champions who will be taken through the basic training of QI and in improvement. So then, when we had a 3-day workshop, we dedicated actually 2 days to make them to have them grasp the basic skills in improvement. And before the end of the workshop, the output was that they're supposed to, in consultation with the colleagues in their departments, come up with a project that the department will work on at the end of the year. And then they will give them all departments, all the QI projects that we have. They will have an opportunity at the end of at the close of the financial year to showcase their work, and also help them come up with posters, which we can be supported through publications. And then that way, every other department or unit in the facility will have grasped the element of QI and improvement, which they can duplicate. So our target is by the end of 2-3 years, all staff will be able to initiate, sustain a project using the a standard way.
Okay. Okay, thank you very much, Gerald. We appreciate that. Let's give Gerald a thumbs up, give him a clap. I wonder how many of us have our patient satisfaction statistics. How many of us are following up and paying attention to what is happening and our patient's point of view of our work? Looking for the, oh, sorry, there you are. Now, Aisha's presentation. Aisha, you can come on. Remember, you can ask your questions in the chat. After all the 5 presenters will give you a chance to comment, speak directly, give what is happening in your institution. Are you having a similar experience? But let's go ahead and hear from Aisha Saidu from Nigeria, from the EHA clinics.
All right. Thank you so much. Hello, everybody. Thank you for having me on here. I'm very delighted to share our story at EHA Clinics, which is from data to daily practice, our lean maturity journey. My name is Aisha Amir Saidu, Senior Manager of Continuous Improvement Office at EHA Clinics Nigeria. We're a primary healthcare facility located in 3 states and also 7 locations within those states. So the quality department at EHA Clinics is led by myself and 2 other team members, Fatima Bakar and Vida Nanabadu. The department is basically to focus on driving and sustaining quality management systems with lean as our quality framework across the organization and quality and safety as our foremost priority and true north. So before I take us through the whole, story around our lean maturity journey, I would like to explain a simple meaning of lean, which is a quality improvement methodology that identifies and eliminates non-value added activities within the organization while increasing value and improving efficiency. So I'll take us through what our story was like. So we implemented lean in 2021. And when we began that, of course, we improved and we identified different tools and methodologies that we think, would be good to expect safer systems, more efficient operations, and engaged staff within the organization. Then in May 2023, we decided to go through our lean maturity assessment just to sort of gauge where we are in terms of our lean maturity journey, where we identified some few realities, right? After so much work being done, we noticed that, our progress lacks, a little bit of depth, where we noticed our leadership communication wasn't transparent enough, frontline engagement was a bit patchy, and, structured problem solving was missing. And of course, the risk was clear where we needed to look at, being that is a lean transformation journey, we needed to strengthen the foundation and, see how we could cover these gaps that we've noticed. So we delved into an improvement strategy where we looked at how would our leaders model transparency, right? How would our leaders shift their role from being in performance inspectors to being coaches and facilitators? So rather, instead of asking team members, why isn't this target met? How would they ask about what the data means for their team and how can we all improve together? We also implemented daily management system, which is a daily tiered huddles. So a huddle is more like, a check-in with the team, but then this was done across the 7 locations. And then, visibility was made where team members in different locations were able to understand or able to see what the data are, in terms of patient satisfaction scores, in terms of how many patients are being seen, even in terms of incidences like risk of fall, basically trying to learn from different facilities. We also introduced the Gamble Walk, which is a leader leader methodology where the leaders go into the workspace to be part of the routine, giving the staff, and patients a stronger voice in decisions. We also trained over 239 staff at the time in A3 problem solving, which is a tool that helps everyone has a structured way for tackling challenges. We also incorporated the technology that we had, which is a visual project management platform to share our stories across the different locations and make our progress known visibly to the teams. So basically, this wasn't about tools, but it was just about a way of, building a culture of openness and shared ownership for all team members. Now, an outcome around that is, by November 2024, we ran another lean maturity assessment where we noticed the participation of our Gemba works have increased by 30%. Our leadership transparency also grew by nearly 10%. Our daily management system improved by 11%, and our adoption of A3 thinking rose by 20%, right? I think, overall, the greatest lesson for us was that, lean has to be driven from the top, right? So leaders have to show vulnerability. And also, we need to incorporate the quality improvement methodology in our day-to-day activities. So it's not really about just doing your QI projects and all that, but you need to incorporate it in the culture of the organization. And then also, when staff are given the right tools to solve problems, patient safety becomes everyone's responsibility. So I would like to close by saying that, this transformation is still ongoing. And the idea is that we are continuously improving. And then we also do not leave that for the leadership alone to handle. We ensure that, all staff members across the different locations, across the different departments have that mindset of lean. And then from a framework, it becomes like a living culture for quality and patient safety. Thank you.
Thank you very much. Thank you very much. There's something you mentioned yesterday when we had the rehearsal. Was it yesterday, the day before? When I asked you who was the team who put this together and how is it being able to work in the hospital, you told me maybe go ahead and tell us a little bit more about the team.
Okay. So we looked at it, from a team perspective, where a team was curated under the Continuous Improvement Office, which is more like a quality department. And the team just comprises of 3 people. So like I said, myself, and then I have an assistant manager and also supported by a lean and quality officer. But what we try to do is we act as coaches, right, to the organization, where we try to provide each and every one of persons in the organization with the sustainable tools to ensure that, they incorporate lean in their different activities. So yeah, that's basically, so we're a small team, and the idea is to keep being small and seeing how we could really mentor all the different team members in the organization. Thank you.
Fantastic. I think let's go ahead and give Aisha her thumbs up, give her her flowers, give her her claps. I think one of the things that's really interesting as we have read through the stories is the different methods, different ways of forming teams in order to have and influence throughout the hospital. I think it's been interesting hearing about the different formats for that. I want to welcome Eunice from Ghana. Eunice, I see you're saying your network is not good. Let us. Or is it my network that is not good? Eunice, if you're available, you can unmute. Actually, I think we'll go ahead to Dikeledi. So Dikeledi, go ahead and share your screen. We'll come back to Eunice after that. Dikeledi, you're on.
Hello?
Yes, go ahead.
This is Eunice.
Oh, this is Eunice. Okay, sorry.
Yes.
Then let's go, Dikeledi. Eunice, you please wait for Dikeledi. So please wait for Dikeledi.
Okay.
Dikeledi, the floor is yours. We're waiting on you.
Good afternoon, colleagues. I'm Dikeledi Msetla from South Africa, Oram Institute Operation Phuthuma. I'm a quality improvement coach under the leadership and guidance of Lauren Tikok. What I'm going to share today is a story from Sundumbili Community Center, which is situated in KwaZulu-Natal, which is one of the provinces in South Africa. This facility is situated in the semi-rural area of Mandeni. It offers primary health care services to a head count of 15,000 patients per month, and the total number of patients registered on ARVs is 9,163. So in this facility with HIV care, there were several problems. You see, when we initiated, the bucket is not getting full, so they are transfer out, missed appointment, all those problems. But for this facility, the main problem that they looked at, it was missed appointment. These are some of the root cause analysis. The patient files were not prepared before the clinic visit, and there was no system of tracking the missed appointments. So the strategy used is the Operation Phuthuma Nerve Center approach, which is implemented through the 4A model. And then it was introduced to the facility and to all the health sub-districts in South Africa that we have. And in all these levels of health, they sit in nerve center meetings where they problem solve. The quality improvement work is discussed and reviewed in these nerve centers at all these levels. So the method that was used at this facility, patients' files were now prepared, wherein now the patient will be called to see why they've missed their visit. Then the files that are pre-retrieved before and prepared, they'll be put in this cabinet. After a patient has those that have missed the appointment for that day, their files will be put in box 1. These boxes represent 7 days of missed. Then after they've not been found on phone call, and those that were unable to be reached, they'll then, after the 7 days being physically traced, a home visit will be done to go check up on them at home to find out the reasons why they didn't show up. And then the outcomes are recorded in relevant registers. There's HAS champion, the HAS champion at the facility level, then looked at, verified the outcomes, and then the outcomes are captured into the Chat.net, which is a system that we use in South Africa to capture the outcomes in HIV and the HIV program. And then the results thereof, by August 2024, the facility had already gained 358 patients and were retained in care since the start of this approach, which was then the QA work was started in July 2023. And then by last month, August 2025, the facility has, as you can see from the graph, the facility has continuing sustained their improvement work. And then by August, the facility performance was now at 99.5% against their target, wherein they had retained 9,715 patients in care against their target of 9,755. So the lessons that were learned through this QI work is that during the initial phase, it was difficult because there was staff shortage, there was no budget. So team members, they had to take extra responsibilities on top of what they are already doing. And then even through these challenges, because the team was focused and they worked as they were still able to achieve what they wanted to achieve, which is the improvement of their indicator. And then what we've also learned that is that retaining additional patient in care, it also assisted the patient care services and the healthcare outcomes, in a sense that once they are retained in care, we are able to come to the facility. We know where they are at the facility, and then they are now offered services. They are now, their viral loads are also suppressed, and at the end, even the community is now benefiting, because now we know that if your viral load is suppressed, then you are unable to transmit the viral load to the other people. So what do we recommend? We recommend that above site management is critical. It's important, because as we're busy with this QI work, above site managers who are supporting this facility, they will support and come to the facility, assist the facility staff to unpack their data, identify their gaps. They also facilitated the provision of the required resources like your registers. So managers from the 4 different levels were able to were coming to the facility and supporting. And that is important, because it also assisted the retaining the progress of this project. So also saying data verification is important, because now as data is being verified and captured, it also translates to report and also able to showcase the work that has been done. And then we recommend that using a system that helps you to track the patient who have missed appointment on a daily basis is important. It can be used in different disease areas, not only in this HIV area. And then we said, however, for this system, this system that you use to identify to identify your patient versus those who should come versus those who are supposed to come. It also saves you from, because your additional resources are directed to relevant place where they'll make an impact. In this project, the additional resources were now directed to home tracing, because now we know that we knew the number of patients who were supposed to be home traced and those who didn't come. So it's not everybody who has been home traced. And then I thank you. These are the acknowledgement. And then those who want to know more about this approach, there's the link of this handbook at the chat. You can download this handbook and then look at the handbook. And my email will also appear in the chat. Those who also want to reach out, they can reach out through email to be assisted and understand, and so that we can share this improvement work.
And thank you so very much. I think it's a fantastic innovation. I think a lot of times we are waiting for for digital solutions, while what we need to trace and track our patients is much simpler. I think it's a fantastic innovation, and we congratulate the team at Oram and Dikeledi. We really appreciate you sharing the 7-day box system with us. Now we go to our last presenter from Ghana, Eunice. Please unmute and go ahead.
Hi, everyone.
Hello.
This is Eunice Tangram from Ghana, presenting a quality improvement project that was carried out in one of the health centers in Kasna-Nankana Municipal, which is Kogo Health Center. The problem we had was we had most of our pregnant women coming for registration late. And ideally, a pregnant woman should visit the facility before the 12th week of pregnancy. So after noticing the problem, we went into our data and realized that from the beginning of January to June, we had only 33.3% of our women coming to register early. So we decided to give ourselves an aim. So we said, okay, we will take this up as a project to work on it. So we said, okay, then moving from 33.3, then by the end of the 3rd month, we should get to 60%. So our aim was to increase our first registrations in the first round from 33.3 to 60%. So yes, how do we do this? So it means we have to identify the possible causes, reasons why the women were not coming early. So we use the fishbone analysis. That was when we identified that some beliefs, cultures, and the absence of an obstetric scan, finances, and our clinicians not referring suspected pregnant women to the midwives were some of the possible causes and reasons why some of our women were not coming early for antenatal. So, okay, then we look at the various interventions. So these were the strategies we used. We said, okay, one, when a client comes to register for pregnancy for the first time, let's go ahead and register her, then follow her up to be able to do the scan. Then secondly, we said we will liaise with our TBAs, our opinion leaders, our traditional leaders, so that they'll be able to help us in that regard to talk to their people, for them to know how important it is for a client to register early when pregnant. Then the third was to follow up. So we conduct follow-up visits during our home visit to be able to identify pregnant women who have not been able to come to the clinic to register. Then the fourth and the last intervention was to carry out a urine pregnancy test by our clinicians when they suspect a woman is pregnant. So that, in fact, throughout these interventions, the urine pregnancy test was the one that gave us most of our clients. And the results, so after the intervention, we met bi-weekly and used the series chart to see whether we are progressing or not. And yes, at the end of the day, the results we achieved. So we had 68.2%, which earlier we said we wanted 60%. By using these interventions, it helped us to get to 68.2%. And like I said earlier, our clinicians supporting us in testing when they suspect pregnancy and referring to our midwives really did a great job. And the lessons we learned was that first, we made it. Because sometimes you think that you will not be able to do something, but yes, we made it. We achieved our aim, and our ANC, our antenatal registrations improved. Then it also increased the staff's capacity to be able to accommodate stress. And also, you know, most of the staffs, usually they have the work they do, then you bring a quality improvement project, then it becomes an issue. By the end of the day, they really appreciated the work that we did. So yes, we recommend that registrations at our antenatal clinic should be done for the pregnant women who would come. Whether the person has been able to do the ultra scan or not, then later we follow them up. Then the second recommendation was that ultrasound machines should be available at various health centers so that a pregnant woman will not need to trek a long distance to be able to have the scan done. And this would also help reduce the issue of finances. You know, some of the women will say, I don't have money. That is why I've not been able to do the ultrasound. Because the facility I am talking about is in a rural community. So we concluded by saying that the point of care quality improvement projects we carried out demonstrated that structured interventions and community engagement that can significantly improve first trimester ANC registrations. So the health center continued reviewing the data, ensure urine pregnancy test kits were available, and maintained strong ties to sustained improvement that we achieved. Thank you so much.
Thank you very much, Eunice. This is fantastic. I think let's give her flowers. And as we do so, I invite each and every one of us to begin to think about what is it you've learned, what is it you shared. If you're here and your story was not amongst those that were shared today, how will you ensure that you're a part of next year's storytelling month? How will you ensure you're a part of it? Remember that all these 34 frontline innovations are available on the LinkedIn page of ISQua AfCOP. All of them were posted there, and so you have a chance to go there. I think you can also, we tagged the authors of the stories, so you should be able to find them and reach out to them on their LinkedIn. But now we have a couple of minutes, I think about 25 minutes, to really hear from those of us, the 147 of us in the audience today. And I think, one, if you have any comments, any questions for the 5 storytellers, but also I think we have 3 questions we really want to have a discussion about around the frontline innovation, and how that can be something that is sustained, that is scaled within our institutions. We will be looking at the chat, and I think maybe put up your hand on your name. Basically, put up your hand if you would like to have the opportunity to speak, and we will go ahead and give you that opportunity. Sinead, please help me look at that. Please help me pay attention to the participants. If anyone has their hand up or if anyone has a question, we will give you the opportunity to share. Thanks, Sinead. I see your thumbs up. So this is the moment for the audience. I see that there was already, Dikeledi has shared the link to the Nerve Center handbook in the chat. I'm also seeing that, oh, yes, Gemechu has provided a pretty good answer to someone who was asking about how they went about raising their quality. Okay, there we go. Asabe Timothy, please go ahead. You can unmute yourself.
Okay, good afternoon, and thank you for this webinar. It was really inspiring. So I like the presentation from the storytellers. Well done for the good work. So to respond to this, how does frontline innovation become institutional learning? Well, I would say first and foremost, there should be a channel, let's say mechanism for where health workers can be able to submit their ideas or innovation. And there should be also a review of those submission and the provision of feedback on their performance. And if an innovation becomes successful, they were able to implement, let's say by testing it using the PDSA cycle or piloting it in a small scale. So if this learning works, they can be scaled up to like other units of the facility or the health institution, and other people can also learn, and they can be given an opportunity to share their stories with other healthcare professionals within their organization. Let's say, for instance, now here in Nigeria, in a facility where we are working, we were able to implement a QR project on routine TB screening at the OPD, that is the outpatient unit. So after we've done that, we were able to complete the project, and it was just at that unit, the OPD outpatient unit. So when we share the success with the entire facility during one of our monthly meetings, so it's a story that was captivating, and it's something that can be replicated. So the other units, ANC units, also replicated routine ANC TB screening in the ANC unit. So women also in that coming for ANC, they were being screened for TB, and they were able to get positive cases. So this learning now was institutionalized by, we make it as an SOP that in the entire facility, all the units of the facility, anywhere patients are coming anywhere patients, you have contact with patient will now be screened for TB. So it has been embedded into our protocols. And during onboarding, when we have new staff, we also incorporate it into their training materials. So this is what we are doing in the facility. Now, any patient that come into the facility, anywhere you are supposed to screen that patient for TB. And that has become our SOP for screening patient in TB, and it has also increased our positive identification, that is TB positive identification. So one, these stories need to be captured, and if it is successful, they need to be scale it, and they need to be integrated into the health institution or facility protocols to become institutionalized. So thank you.
Yeah, thanks. That's a great idea. Now, is your name Timothy, or are you just using Timothy's handle? It
Okay,
sounded like not a Timothy.
my name is Asebe Timothy.
Okay. Okay. So it's Ashabe Timothy.
Yes.
I agree with your challenge. Please do share your wonderful innovations, and I'm sure we'll be more than glad to include you next year. Now let's hear from SMA.
Right.
SMA, go ahead and unmute. I see there's people also commenting, Hannah Saidu saying that she has learned a great deal from this. Hoda Darwish as well saying the stories of the improvement projects are good work. Kasahun saying thank you for it. So let's go ahead, SMA. Okay, if you're speaking, you are muted. You do need to unmute your microphone. Sinead, you can allow Eberechi Ukchu as well as Stephen Kizito.
Hello, good afternoon. Ruspel, can you hear me?
Please go ahead.
Okay, so thank you very much for this very interesting, very insightful presentation. I just want to first of all reflect on the first question, and that's how does frontline innovation become institutional learning? And I think one of the first things to do is actually to encourage the teams to be innovative, encourage autonomy in your quality improvement teams or your quality assurance personnel, and let them know that the floor is actually open for them to share their ideas. And once that is done, these innovations need to be captured. They need to be documented. And just like Asabe said, it's nice to align those with your operational frameworks. For example, in SOPs that are used within the institution, or even in the drafting of guidelines for quality or for assessments. And that ensures that as an institution becomes like a part of the practice in that institution. I don't know if I can move on to the next question so that I don't come on
Yes,
board
please go
again.
ahead.
But
Keep going.
okay. So with regards supporting teams to move from project to publication, I think it's critical to get the teams to document everything they've done. As we've seen from all the presentations today, there was a lot of documentation at every step when RCAs were done and when the improvement projects were actually instituted. All these things were documented and helped them to share a credible story that can be replicated by any other quality team elsewhere. So documentation is one critical step. We must provide teams with the tools they need to document. So I shared a story from NHIA's quality capacity building. And what we did was to start documenting the capabilities before the modules were actually curated for that training project. So that's on one hand for documentation. Another thing is to also have some kind of skill in analytics, because of course, if you document and collect data and it can be analyzed, then it really doesn't tell much of a story. I know that the analytics was a very key part of the submissions for the storytelling this year. So it's good to build the capacity of the team to also carry out data analytics, from data visualizations or just using Excel sheets to analyze the data in pivot tables so that it gives a visualization of the work that has actually been done. And thirdly, I would say it's essential to have some kind of external review of the project before publication. And ISQua AfCOP did a very good job of that. We received feedback on our storytelling that can help us shape the story into something that can be published in a peer-reviewed journal. So it's critical that, okay, when we've documented our work as teams and we've done the analytics, it's also good to share with some other person or body that is that can look at the submission and also give feedback that can enhance the story and make it ready for publication. I think that's all. Okay, so for one last
congratulations to you too. We should be congratulating you too, because there was a selection of those to speak today, but you're amongst the 34, and we want to thank you and also thank the reviewers who took time to give that feedback that I hope has strengthened the way that you're able to tell your story as well. So congratulations. I'm going to move on to SMA, and I can see Lydia, whose hands are up. We can help give them the unmute button.
Thank you very much. Yeah, thank you very much, AfCOP committee, for planning this and the great presentations that have so far come. I think I'd love to chime in on how to have curiosity, how to inspire the frontline to be curious. I think is coming to work knowing that there's opportunity, whether to see something, an event, that incidents do not just happen, whether they are in the very good or not so good, and whether they're affecting the staff, like just moving in what does it matter to this nurse, to this doctor, that their patients get good care, and what can they think can be scaled. So I think being curious can either come organically, or if we have opportunities to pause. Are there seasons that we pause and we reflect on, this is what the data is saying, these are the incidents, we've been recording them, but now these are the numbers. So I think when we have opportunities to reflect, and I love in my team having group reflections, when together we are looking, okay, so what do we want to do this season, maybe at the end of a quarter or mid-year evaluation. So I'm thinking that having structure can help you to bring together these small fires of enabling now the curiosity now, not just to be all over, but to be structured. And so as you reflect on what has happened and you brainstorm, then you're able to come up, why can't we try this? Or this has come up in a different department. How can we address this? How can we be of help? And so that bringing together brainstorming, but over data, over incidents, because we keep documenting. And the more we have some form of, do we call it passive routine? Let us see what can we put in our routine in terms of capturing data, and what can we put as a unique documentation. So the more we have some routine data collection, the more we can look at the trends and the more we can reflect on it. Another opportunity is the external factors that throw us out of cycle, like you get new health financing approaches, a new system in the hospital. So that's also an opportunity of saying, amidst this challenge, how do we address this in improving the care? Because this new system is making us delay. This new system is affecting the patients. So at times the lemons that life throws into the health sector, including the funding challenges from the Trump world. So those make us reflect. So how do we reduce the pain points? Because we've shown up being curious, but then now we have a real issue to address. I think those are the comments that I needed to make. Otherwise, the storytelling presentations are very insightful. I hope you're learning just as we are from what our brothers and sisters are doing across the continent. Thank you very much, Sinead and Ruth Pal and the AfCOP team. the great presenter.
Thank you very much, Lydia. I just want to take up 1 more minute of your time. You've talked about gaining curiosity within the institution, within the leadership. I want to hear, how did Lydia Okutoi get to be curious about QI work? I think there's how have we found ourselves here? I think that's a part of it. Whatever makes us curious as individuals before the institution. Maybe tell us a little bit about that. How did you begin to get curious about patient safety and quality improvement work?
My background is in obstetrics, so one of the things that made me curious was we had duty rotas in our labor ward and in our main obstetric department that you do your work and go away. But over time, as I started looking at supporting the quality assurance department, which I thought you just attend the meetings and go away, but I started observing trends that there are times something could happen and it happens again. So it's like, how comes the system, the person who came on duty in the night did not realize that we had more than 70 women in labor and they needed to do this. So when you'd go to look at the data, it would tell patterns and trends, and at times there would be incidents that are fairly emotional and some that were outlier and really life-saving events. And I'm like, okay, I think we are not talking to one another. It is possible for skills that maybe are not part of the clinical skill set of missing a mother in labor and doing a cesarean section, that helps us see what are these complexities that affect our outcomes and how can we together, both in terms of information and appreciating the risks, because we are referral hospital and so we'd have patients who are high risk. So I think one of the curiosity that was pulled out of me was how comes we are not learning? I mean, the information is not flowing. What I'm seeing, how comes other people are not seeing? The HOD is seeing, but this other doctor comes and does their work and goes, yet at the end of the call, you hear, oh, this happened, like it wasn't picked. So then we realize that having the quality improvement approaches, including appreciating that outcomes are affected by how the system interacts with one another, and we can tweak 1 or 2 things to ensure that outcomes are improved. So that was one of the main things. Thank you.
Thank you very much, Lydia. That system-wide quality transformation is something we all have to really be honest is a big need on this continent. I can see Aisha in the comments. Aisha was a presentation from the EHA clinic in Nigeria saying, yes, the lean tools really supported their clinic in going beyond individual improvement to actually system-wide quality transformation. I'm mentioning these things hoping that we are all getting inspired and thinking, okay, how do I get this to work in my own institution? But I think we can go to SMA, whose hand is up, and then we can go to Zenabu Baba as well. We'll take maybe 3 more people and then move over to Elom, who is giving us our closing. SMA, you can go ahead and unmute. If not, Zenabu, go ahead and unmute.
Hello, good afternoon, everyone. Good afternoon from Ghana. Yes, so I would want to comment about to answer the question, how does frontline innovation become institutional learning? So from my experience working in the obstetrics ward, I think that for you to prove to your institution that you've done something good, that you've innovated something they can all adopt, what you've done should be successful. And for it to be successful, you have to persistently review what you've done and solve the challenges that the frontline workers may be facing. An example of this is we in our facility implemented the modified early obstetric warning score. We integrated it into the EMR. Initially, we were only using the regular vital signs. So The midwife or nurse will check the patient's vital signs, the blood pressure, the pulse, oxygen saturation, record it, look at the numbers and say, oh, I think the oxygen saturation is low. So let me call a doctor. If the changes are subtle and several and she doesn't notice it, the patient will be on the ward. And then the next thing you hear, oh, a patient is gasping, call a doctor. So these things happen every now and then. So when we learned about the MUSE, the Modified Early Obstetric Warning Score, we now had to ask ourselves that, okay, we are now using the EMR. Most of the people using the MUSE, other teaching hospitals in Accra, like Kuala Lumpur Teaching Hospital, they were using the paper format. So maybe if they check your vital sign, it falls on a red or 2 yellows, then it triggers, it's an alert. But then we now were using the EMR, the electronic medical record. So how do we put it in? So we had to brainstorm with the IT department of the hospital. And I want to believe that Mr. Edwin Zei is on the call. He was very instrumental and helpful. And we integrated this into our EMR. But for it to work, this was something new in the department. They were not used to the MUSE to start with. And then now we have to integrate it. And for people to accept a change, you have to make it seamless. Because once they begin to feel uncomfortable, then everybody wants to stay away. But for it to be successful, we had to be talking to the midwives. What's the challenge you have? How do we make it better? And then we have a conversation with the IT person, and he was very helpful. And then it's all about customizing it so that it's easy to use and easy to implement. In fact, one major challenge we faced was moving a patient from, let's say, the maternity theater to the lying-in ward. How do we know that these are the vital signs of the patient when the patient was in theater, and these are the vital signs when the patient was on the ward? We can't mix it up. And sometimes when a patient maybe gets acute, you may have to take the patient back to the theater for a re-laparotomy. So the question is, how do we know which vital sign is for what? So working with the recovery ward staff in the maternity theater, as well as the IT personnel, as well as the midwives on the ward, we came up with the idea that, okay, once a midwife is posted to the lying ward or a staff is in the recovery ward, on the EMR, we have something like our profile. You sign in with a password and your name appears on the EMR. So we needed to integrate that in the vital signs that the staff enters into the system. I don't know if you get me. So once you make an entry, it appears, and then the action that you are supposed to take, which is part of the MUSE, the action will just pop up and say, call a doctor or continue as you are doing, or send this patient to the high dependency or call a consultant. Yes. So once that instruction comes, your name comes and your profile comes. So for example, if you are a theater staff, it comes saying theater nurse. If you are a lying ward nurse, it says maybe maternity ward nurse or Yeboah ward nurse. So using your designation, we were able to solve that problem, to trace the patient from one point to the other. So for me, if you want to implement an innovation throughout the hospital, then your initial one should be very successful, and your success depends a lot on talking to the frontline workers, solving their problems, listening to them, and not taking anything for granted or saying, oh, this is okay, this is not important. And if you are dealing with a digital system, then you need a very patient and hardworking IT person to work with, and which I would say in Texas Military Hospital, we had in Mr. Zay. Thank you very much.
Thank you very much. What a great story you have told us as well of improvement. It's so good to hear all of the work going on in all the countries. SMA, I'll give you a final chance if you're able to unmute. If you are not able to unmute, we shall go ahead and offer, I think, the congratulations. I think we can all put our hands up and clap and tell everyone, well, very, very well done. What a wonderful example. Okay, I think let's give Sam the chance for SMA. Sam, Asia, did you put your hand up? I see it up and then I see it down. If not, then I will then invite Elom Ochi a doctor from Ghana to the platform. He is actually going to be representing Africa at ISQua in Brazil. So those who are going to Brazil, this is your chance. Please make sure you say hello to him. I just also want to mention that I know Sinead and the team will be putting everyone going to the Africans from the AfCOP who are going to be in Brazil, in Sao Paulo together, into a WhatsApp group together. So please make sure you don't miss out on being a part of the group so that we get a chance to network, talk to each other, strategize, maybe share resources when we are together in Brazil. So let me go ahead and welcome Dr. Ochi.
Yes, so thank you very much, Ruth Pal, and thank you very much to all the colleagues. Please, can you hear me? Yes.
Can hear you.
Good, and thank you very much to all the colleagues who presented. I think congratulations is fair. So congratulations to all of you. This opportunity to publish your quality improvement projects. I am sure for many of you, including all the 34, this might be the first time, but for others as well, this might not be the first time. So we congratulate all of you for this well-deserving effort. And we would like to encourage, like has been said, other colleagues on the call, that we proceed to publish again, but this time in some peer-reviewed journal. Fortunately, ISQua has two peer-reviewed journal that you can submit these beautiful works to. So you can work on it as a team. Go to the journal website and then look at the guidelines and what you have to do, and then just clean it up and submit. And then you can also get it into a peer-reviewed journal to be read also by other audiences. And so that's what I would like to advise, as has been indicated already. And also for us to also remember that we are doing this as part of the World Patient Safety Day celebration, which has been earmarked by the WHO for member countries to commemorate or use the day 7th September every year to raise awareness on patient safety. So this is our little contribution to that particular event, and we would like to encourage you that in your countries and your health facilities, you should keep the fire and the flame and patient safety and quality burning wherever we find ourselves. And finally, I mean, as we have discussed today, we see that the challenges to quality improvement and patient safety are very real. But we also see that there are many opportunities that abound. And I would like to encourage all of us, including myself, that we take today's session and the discussions we have had as a starting point and as a beginning, so that we can further reflect, so that we can further take the necessary action and collaborate. And I close by emphasizing that quality is a journey. Quality is like eating the meat of an elephant. I suggest that we chew it in bits. Otherwise, any attempt to think that we can do all at once, or we can address all our institutional problems at a go will cause us to choke, and we might be disappointed as far as the journey is concerned. So let's take the journey and the process in bits. It's baby steps, little by little. And I am sure, as we have seen from the presentations, they were baby steps. And with time, they were able to get to their various destinations. So I encourage all of us that we take baby steps, identify the opportunities in our facilities. And with the baby steps, we are able to arrive at our desired destination. My colleague has already invited all of us to Sao Paulo in Brazil. And I also want to encourage all the other all the other colleagues to prepare and dress up your abstract once again. Next year, ISQua is in Dublin, Ireland, and I'm sure that we can increase the number of posters in Ireland as we have done as far as is concerned. So congratulations once again. And finally, I don't know how many times I have said finally, but this webinar series, we do this every month, and it's the first Thursday of every month. Kindly join us and follow us on our LinkedIn pages as other colleagues have indicated. And I am sure in November we will be serving you another sumptuous meal as far as quality and patient safety is concerned. So thank you and see you in Sao Paulo for those of you who will be going, and catch you again at our next webinar series virtually. So thank you and best regards. Ruth Pal, all yours.
Thank you, Elon. Thank you very much. So this is us saying goodbye. This is us saying congratulations to everyone doing excellent quality improvement work. You have taken many, many steps forward, and this continent thanks you. This is thank you from the Africa Community of Practice group. I'm saying bye-bye. You can share your goodbye emojis, and remember to check out the posters on our LinkedIn page from the 34 submissions of storytelling submissions. There are going to be opportunities to ask questions, and you can sort of tag, talk to the people that are tagged, so that we can continue this networking work. Have a lovely evening, everybody, and thank you for joining us. Bye-bye.